thank you all so much for joining us. We've got about 20 people joining us so far, and I'm sure we're going to get another couple of folks joining us as the time goes on. So in the meantime, I'll just go ahead and introduce myself, talk a little bit about today's program, and introduce our speaker as more people join us. So my name is Karina Madrid, and I have the honor of working every single day here at the Epilepsy Foundation of Colorado, along with my colleague, Winnie Kogel, who is on the line with us. She and I will be moderating the Q&A box at the bottom of your screen. If you have any questions, you can pop them in there. You are on night 4 of our Epilepsy Connect Symposium. This is our largest education conference of the year, and tonight and the whole week we're actually presented by AZI, and we're so thankful for their sponsorship. This is our largest education conference of the year. We've got hundreds of people joining us, different sessions throughout the week, and it's just been great. And we're so glad you all are spending part of your Thursday evening here with us. So this topic that you're in right now is non-epileptic seizures, diagnostics, treatment, and more. We have the expert here to present on this topic with us, Dr. Strom. She is going to cover a lot of information. We know you have questions. So if you do have a question, go ahead and put it in that Q&A box at the bottom of your screen, and we can either address it in that box or save them to the end and ask Dr. Strom if she feels like she hasn't covered that topic. So with all that being said, I'd like to introduce our speaker for the evening. Dr. Strom is a board-certified neurologist and epileptologist. She completed internships in both neurology and psychiatry, holding a dual appointment in both departments at University of Colorado. After completing her residency in neurology and practicing as an epileptologist, she ultimately decided to become an expert in tonight's topic, non-epileptic seizures. In 2015, she and her colleague, Dr. Heru, conceived of and created a dedicated treatment program for patients with NES. This program has grown to include a psychiatrist, a licensed clinical social worker, a program manager, a scheduling expert, and of course, Dr. Strom directs this clinic. This year, as of this year, the clinic has treated more than 700 patients with a diverse complement of neurobehavioral therapy, including psychoeducation, psychodynamic therapy, medication management, cognitive behavioral techniques, family assessment, and therapy. So if you have questions about NES, Dr. Strom is the expert. She can answer them for you. So without further ado, I'd like to invite Dr. Strom to come on camera and share her screen. Dr. Strom, can you, yep, we can see you. And if you just want to unmute, we'll be able to hear you. There you go. Great, okay. We'll take it away.
Good. Okay, so good evening, everyone. I'm so glad you're here, and I'm really grateful for the opportunity to talk about my favorite thing, which is non-epileptic seizures. As Karina said, I've been doing this for the last 5 years exclusively, and in the past year, I've had just the great honor to devote myself completely to non-epileptic seizure care. And so I want to bring a lot of information to you tonight. And as Karina said, if you have questions, just put them in the chat box or the Q&A box, and we will try to address them. So let's see here. Oops. Okay. So how do we define non-epileptic seizures? And what does the DSM say about non-epileptic seizures? That's the DSM-5. And what in fact is the DSM? People will like to know that. The criteria are, this is kind of a busy slide, but it's straight out of the DSM, and it's the criteria for what we now call functional neurological symptom disorder, conversion disorder, is what it used to be called. And if you, boy, I need to make my slide a little bit bigger here so I can see it. Okay, so in order to get the diagnosis of a conversion disorder, and in this case, functional neurological symptom disorder with attacks or seizures, you have to have one or more symptoms of altered voluntary motor or sensory function. And then clinical findings that aren't compatible with, in the case of non-epileptic seizures, epilepsy, although some people have both. And then the symptom is explained better by something else. And it causes, and this is key, significant distress for the patient who has the diagnosis with impairment in any social, occupational domains or other important areas of functioning. And as I said, in terms of non-epileptic seizures, we say functional neurological symptom disorder with attacks or seizures, but you can see there's a whole selection of different symptom types, everything from weakness or paralysis to mixed symptoms. And many of our patients have mixed symptoms. The DSM is really a descriptive kind of tome. It's used internationally, although it's developed in the United States. It's in its 5th edition over many years. And the DSM doesn't really talk about cause. We're going to talk about cause tonight. We're going to talk about a lot of things. But the DSM is a descriptive manual so that neurologists and psychiatrists all over are using the same language. At the very bottom, you'll see that there's a, I don't know, maybe it's kind of small, but basically what this says is they want you to specify whether there's a psychological stressor or there's not a psychological stressor. And this is a really important point because up until a few years ago, you couldn't make the diagnosis of non-epileptic seizures without proving that somebody had a psychological stressor. And the people who were in charge of developing these criteria have realized over time that it's actually not necessary to identify that. Many people are diagnosed with non-epileptic seizures without any evidence of a particular stressor. So who gets non-epileptic seizures? And many of these slides are duplicates of last year, but I've updated some of the data in these. But I have produced some new. So some of you who were attended last year might recognize some of these. But there's still the same ratio that we talked about last year, and that's 3-to-1 female to male. That's a national figure, but it's also the figure that we've got in our clinic as well. I think it's important to note that 62% of the patients that we take care of meet full criteria for PTSD. There was a question that I got before the presentation, and I'm going to be addressing trauma in my talk. I want to also really point out that 93% of our patient population has some history of trauma, even though they may not meet full criteria for PTSD. So this is a very traumatized population, and I think it's important to recognize that. More than 75% of our patients, and this is true in other studies as well, have anxiety disorders. If you look at community statistics, you might think, gosh, this isn't such a huge deal because only 33%, or rather 33 out of 100,000 patients have non-epileptic seizures. But what we know when in a referral center is that 25% of people walking in the door of an epilepsy center are going to end up with a diagnosis of non-epileptic seizures, whether that's NES alone or whether it's in combination with epilepsy. What we know in our epilepsy monitoring unit is that anywhere from 30 to 40% of the patients admitted throughout the year end up with a diagnosis of NES. So in our hands, this is actually a big number, whereas in the community, it's really considered sort of a rare disease. The average age of the NES adult patients is around 31 years, and that's in our data as well, but the range is on average between 18 and 47. And I can tell you that we take care of 50-year-olds, 60-year-olds. We've had a couple of 70-year-olds. So it doesn't respect any age. Anywhere from 10 to 20% of our patients also have epilepsy. So a lot of people, ask me, well, what is an NES, what does a non-epileptic seizure look like? And I think it's really important, just as in epilepsy, to tell people that it takes many, many forms. We have patients who can have very mild events with just a little bit of shaking. We have people who have loss of awareness and they don't have any shaking at all, nothing visible. They just seem to be down for the count. People tell me, and the quotes are around full blown, because that's what people will tell me, that they have full blown convulsive activity. And these are very frightening to both the patients and the loved ones, as are any of these events, frankly. In short, I think it's important to know that non-epileptic seizure signs and symptoms are really very, very variable. And we see that certainly in our patient population. I always like to talk about what people call non-epileptic seizures. And, you know, if you look at the literature, you'll notice I take off the P part because my patients actually don't like to be called psycho. And the P in PNES is for psychogenic non-epileptic seizures. And I called out when we talked about the DSM-4 diagnosis that psychogenic is no longer an actual criterion for making the diagnosis. And that's because we can't prove that there's a psychogenic, there's a psychogenic component at the time of diagnosis in all of these patients. So we take the psycho off at patients' request, frankly. And I prefer to call these seizures non-epileptic seizures. But you can see from this list over time that people have called non-epileptic seizures all kinds of things. You know, at the very least, they'll just say, I'm having a spell, whatever that is, or a seizure-like event. That's a term that I see in emergency department notes all the time. Seizure-like behavior, as though someone has decided to do this kind of thing, or seizure-like movements. Pseudo-seizures is a particularly onerous thing that these are often called, and unfortunately, still being called. I can tell you that in the literature, this is no longer an acceptable term and hasn't been for more than 10 years. Pseudo, if you can read this blurb up here, is actually means not genuine. And that is not true, as I'm going to demonstrate this evening. Psychogenic non-epileptic events is another term, but what is an event? I mean, we're having an event right now. We're gathered together to learn more about NES. So I think it's not a very specific term. I just want to drop down to the bottom and say that at this point in time, there is a move on the part of a lot of people to simply call these non-epileptic seizures. But there's also an equally active move in the UK that's gaining quite a bit of traction to call them dissociative seizures. And then formally, the DSM asks us to call them functional neurological symptom disorder with attacks or seizures, but that is such a mouthful, most people aren't going to use that term. So the reason I spend so much time on this part of the talk is that when I see patients for the first time, I spend probably anywhere from maybe as few as 5 minutes up to 20 minutes and sometimes longer, sort of unpacking the hurt that people have experienced at the hands of, medical professionals who are, I think, well-meaning because they feel as though the names that they're called are pejorative. And what I started doing about a year ago was identifying that people were having medically induced trauma, and we started measuring this. And these are just some quotes from patients of mine. These are real quotes. They rubbed my sternum raw. And that was from a woman who told me that the doctor kept telling her, wake up, and hurting her to wake her up. And then another patient telling me, well, they left me alone and they told my husband I was faking it and so he should ignore me too. And I hear this third one here all the time. I could hear them laughing at me in the hallway, as though somehow the patient can't hear what's going on around them. And then another quote, the doctor got it all wrong and they didn't listen to me. So these are the various kinds of medically induced trauma that I encounter, unfortunately, on a daily basis when I'm taking care of patients. And it just points out the need that we need improved education, not only for patients, but for doctors and other providers taking care of patients with non-epileptic seizures. And I just want to go on record and tell you that that's very near to my heart and very near to my team's heart. And my practice manager is working diligently all the time on outreach. In fact, getting her master's of public health right now, because this is of such interest to her. So how do we diagnose NES? We put electrodes on people's heads and we get an EEG. This kind of fancy looking squiggly line thing here is an EEG. This is a very beautiful and normal looking EEG. I want to just point out that in order to actually see an epileptic seizure, I would need about this amount on the brain in order to actually record it on a scalp EEG. And that becomes important as I go on speaking about this. This is just a diagram of where we put the electrodes on the patient's head. And what do we know about the cause of non-epileptic seizures? Well, really ancient history goes all the way back to 700 BC. Hippocrates coined this term hysteria, and it's comes from the word hysteric, which is Greek for uterus. And back in 700 BC, surprisingly, Hippocrates actually got a lot of things right. But this is one case where he got everything completely wrong. And if you put this in context of the way women were treated back then, it's not hard to understand that he felt that these kinds of problems were being caused by a uterus that was literally wandering around inside the body causing trouble. Now these kinds of things just sound preposterous to us, but not so ancient history. Is just a little over 100 years ago, where Dr. Janet and Dr. Freud thought that this was some sort of hidden stress, that there were traumatic memories that were, playing themselves out in outward symptoms. And Freud called that conversion, which, by the way, we still use that term, and it is not out of the DSM-5 yet. Janet was probably closer to understanding this, and he called the spells seizures dissociation. More recently, studies have been showing that there is a real difference in the way people attend or pay attention to sensory stimuli. And sensory processing is really felt at this point to be quite abnormal in people with non-epileptic seizures. They're hypersensitive. They have poor memory and attention. And these kinds of studies are identifying more and more about the kind of comorbid difficulty with sensory processing that people with non-epileptic seizures have. Currently, our current history shows that we actually just need more studies to investigate how stress and neurobiological stress reactions are altering the nervous system and processes in the non-epileptic seizure population. This is kind of an exciting time, and one of the reasons I just love being in this field right now, because we really are assembling a lot of biological clues. The attentional bias that I talked about up top, this trouble with sensory processing, increased startle responses, which we can measure, increased activity in a part of the brain called the amygdala, which is the part of the brain that processes emotion, especially if there's any threat stimulus processing going on. And we see this played out in people with post-traumatic stress disorder and flashbacks. We can measure the autonomic nervous system, which is a fancy way of saying, the flight or fright response that people have, with checking out how variable their heart rate is. We can also look at stress hormones like cortisol. And I think the most exciting thing, and the place where we have the biggest chance of really understanding the wiring that's involved in non-epileptic seizures, is looking at PET scans and structural and functional MRI scans, as well as those blood tests and measuring things in the autonomic nervous system. So the heart rate and non-epileptic seizures. I think a lot of my patients have heard this fight, flight, and freeze reaction. In fact, I know it now because many of my patients came and told them that was what they were told. Well, this is a measurement of sympathetic tone, and that's just a fancy way of saying adrenaline in your system. Like, how much flight or fright or freeze do you have? People often ask me, well, why do you say freeze? And I'm a country girl, so I can tell you that I grew up with the term, he's like a deer in the headlights. And that means that when you shine headlights in the dark at a deer, they freeze instead of running away, which is what they should be doing. Anyway, this tone, this adrenaline level in people with non-epileptic seizures is measurably higher. And one of the ways we do that is we can measure what's called heart rate variability. In a normal person who has enough of the opposite of the sympathetic tone, the opposite of the adrenaline, they have a lot of variability in their heart rate. And when we measure the heart rate in people with sympathetic tone, people with non-epileptic seizures, we can measure a much lower variability. And that's something we can measure in people with epilepsy as well. The stress hormones that I mentioned, specifically our cortisol levels, and those are higher in people with non-epileptic seizures. And that can be measured over the course of several days. This is actually a very good study showing that people are running baseline cortisol levels that are much higher. So they're in a state of stress, frankly. That's what you're seeing. Last year when I did this talk, I spent a fair amount of time looking at some of the functional imaging studies and talking about them. I got some comments that was a little bit confusing. And before this talk this evening, I got several absolutely excellent questions from registrants in the seminar. So I thought, well, I'm just gonna, in place of the functional imaging studies, I'm gonna talk a little bit about exactly what you all wanted me to talk about. I was given 4 questions. So the first question from a registrant was, are we seeing increased cases of NES? They said PNES, that's a common term, due to COVID stress. So I thought this was very apropos because I was interested in this too for a couple of reasons. One is that some of you know, in order to diagnose NES, as I discussed, we have to have an EEG, and that's an elective procedure. And during COVID, we had to shut down a lot of elective procedures because the hospital got filled with people who were sick with the virus. And so I got a little nervous thinking, uh-oh, we're gonna, all of our patients aren't gonna get diagnosed, and we won't be able to take care of them. And then we're gonna get backed up later because then they'll come in for, treatment later. And so what I did is I measured this. So I have a friend at UCLA who does a lot of statistical work, and he took our data. And basically what you're seeing here, the blue line is last year. And on this axis here, these peaks reflect how many referrals we got in a month's time. So it went, we've got 9, it's somewhere around 7 here, it's up at 11 here, and this is 2019. And what you see here in the brown, kind of orangey brown line is this big gap here because we had to close our monitoring unit in March and weren't really able to open it back up until mid-May again. And so we had, basically no referrals at this point in time. And then we had a huge surge after that because I think people were making up, as I was worried about, for lost time. And then we went on to have the same amount. So I think that this line here breaks off, but we are again seeing a peak and we haven't shut down. So I'm not sure that the answer to the question, to the registrant's question, is yes, but I'm strongly suspecting that, that there may be some COVID stress driving what we're seeing in terms of referral for treatment at this point in time. We also looked at the percentage of people that were diagnosed, and not surprising, during that period where we were shut down, it fell off. And then we've got the last several years of smoothed data of people who were diagnosed, and those numbers have stayed pretty close to what we talked about. And now we've got some big peaks, and I got this data done in August, and so I can't fully say whether we're going to diagnose more people, and that's really structurally difficult to tell because we have had to close the unit, and we're essentially closing it now again as well. So that was a great question from an audience member, and it was really interesting to me to be able to give you some data about that. Another question that I got was, what signs and symptoms help us determine NES versus epileptic events? And I a little bit tongue-in-cheek here, say, NES, can we guess? Because this particular question is something that I've also been very, very interested in. And one of the Residents and I gave a lecture last year about how to predict and how to use signs and symptoms to try to determine whether something is a non-epileptic seizure versus an epileptic seizure. I mean, wouldn't it be nice if we could avoid all that hospitalization and expensive EEGs? Well, the truth is right now, that's what we do. We use video EEG, it's the gold standard, and we get nervous because simple partial seizures, which are epileptic seizures that are hard to see on an EEG sometimes, can fool us. And so it's not perfect. And frontal lobe seizures can look very unusual. And if a clinician is looking at it and they don't know a lot about frontal lobe seizures, they may think it's a non-epileptic seizure when in fact it's actually frontal lobe seizures. They're also notoriously hard to tell on an EEG. EEG is a limited tool. It's not perfect. And so sometimes we miss things because, they're just hard to see. Sometimes we bring people in, we spend all the money and time and patients put themselves out and we don't get enough episodes to really understand what's going on with them. And then historically, physical signs during seizures or the lack of those signs, in some cases, clinicians actually just have to make a clinical diagnosis of non-epileptic seizures. So these are the ways we diagnose. And then, so to answer the question, what does a doctor actually ask a patient when they are documenting getting a seizure history? And this is something that's pretty easy to understand just by doing chart review, which is what the resident and I did. And what we found is that they say, did you bite your tongue during your seizure? That's a very standard question. In fact, almost every single neurologist and even emergency room doctors will ask this question. Did you lose control of your urine is another question that's asked. And then third is, are you depressed or anxious? And generic questions about psychiatric status. Well, we aren't really taught as well as we should be about how to pursue that. And this article here, Differentiating Between Non-Epileptic and Epileptic Seizures, is written by Oren Davinsky and Kurt LaFrance, two just top names in the field. And what their take-home message is that we have to be humble. There isn't any clinical feature that is so specific to NES that we can go, bingo, that person did X, therefore they have non-epileptic seizures. So basically, this is a long list of lots of symptoms as the person asked in the question. And then this is a, yeah, we're going to see this more often in epileptic seizures, and we're going to see this more often in non-epileptic seizures. If you go down to lateral tongue bites, if they're on the side of the tongue, is often something that we see in epileptic seizures, and we don't see it very often in non-epileptic seizures. But no single one of these symptoms is going to obey the rule 100% of the time and always lead you to the right diagnosis, which is why we end up having to use video EEG. On the horizon, this young man that I've been working with at UCLA, Wesley Kerr, is not only a physician and a neurologist in training, but also a mathematician. So he created a predictive model that is actually quite a bit more reliable than just getting signs and symptoms. And he found that it's really not the way the seizure looks or the symptoms that people have, or even the psychiatric diagnoses. It's really about, how many medications they're on currently, how many medications they've tried, and a series of other factors like what else are they ill with, and time to diagnosis, and the number of types of seizures they have. So things that aren't as intuitive end up actually being more important. We're using this calculator not to diagnose. I don't want anyone to think, well, I'm just putting them into a calculator and trying to figure out what's going on. We still use video EEG as a gold standard. But this helps guide us if we're on the fence about some things. It sometimes can push us in one direction versus the other, but we still need the video EEG data. We're working on a validation study right now because this was done at UCLA. Who knows, is their population the same as ours here? And we're getting ready to publish those data. And it looks like this calculator works about as well here as it did in the UCLA population. So we're hopeful that we can use this as something that we do along with the video EEG to really help us understand our patients with non-epileptic seizures a little bit better. So the next question from a registrant was, please comment on the presence of NES with intellectual disability and no known trauma. I was really impressed with this question because it is not something I've asked myself. I can tell you that it doesn't come up much in our population. So, you know, I guess maybe that's in defense of not asking the question myself, but I thought, well, I don't know anything about this topic. So I spent some time and I did some reading. And what I can tell you is that it was a little bit shocking to me to check the literature and find out that when I put a combination of keywords, PNES, which is really how you have to search in the literature, in spite of our opinions about what we should be calling it, and intellectual disability, I only got 8 studies and 5 of them were irrelevant. So this is an extremely understudied problem at this point in time. And the other thing that, you know, is very true, and I know this about all the literature that I read on non-epileptic seizures, is that, or rather epilepsy, that NES is often an exclusion criterion for studying epilepsy. So if you've got NES, not only is no one studying you if you have intellectual disability, no one's studying you in the literature because NES is an exclusion criterion. So proven therapeutics are often not as useful in this population because they rely so heavily on cognitive behavioral approaches. And someone with intellectual disability often can't participate at a level that they are going to find completely helpful. So just to talk a little bit more about this, there's 2 studies that I was able to locate that are fairly recent. And one is from the journal Seizures, and it was published in 2018. And this study was done in the Netherlands. I have to say, it's all I could find, and it was the best study I could find, but I have concerns about the way the study was done. The number of patients who were studied was large. It was 240. But the authors did not use video EEG as a gold standard. Video EEG was only done in 53%. 13% of the patients were diagnosed with non-epileptic seizures just by viewing a video of the actual seizure. And then the remainder were, you know, they just listened to a history and made a decision about whether the patient had NES. So they may not have gotten as many NES, or they may have overestimated how many NES. They found the same things that we find here, that there were more female than male. They characterized the intellectual disability for they used the WAIS, which is, you know, it's a standard IQ test, and a Vineland-2, which is subscale looking at the way people are socialized and how they can cope with daily living activities. And most of them had moderate intellectual disability. And then what they did is they compared the 2 populations. They looked at, you know, depressive symptoms specifically and quality of life. And they found that in people with intellectual disability, there were more depressive symptoms and more people reporting a lower quality of life in that cohort. And then the next study that I looked at was therapeutic intervention, which was really the specific question that was asked. And what do we do for these people? There was a study that was done in 2017, published in 2017. And this study came out of Scotland, where they have national health system, just like in the Netherlands. And so they have a lot of good record keeping. It was a very small study, so that's a weakness of it. It was only 46 patients with intellectual disability. They also compared that with another population in their clinic of 106 patients with non-epileptic seizures who didn't have intellectual disability. And again, they clinically established the diagnosis in about 30% of the cases. So it's a slightly higher percentage that were done with video EEG. What they found is that the onset of non-epileptic seizures ends up being a younger age of onset in people with intellectual disability, and that was a statistically significant finding. They found that there was a trend, it wasn't statistically significant, a trend for people with non-epileptic, being free of their non-epileptic seizures was higher in the group that was did not have intellectual disability. I think the interesting thing is that in the two groups, the use of cognitive treatment was equal in the groups. So I was really impressed with that. And I think I need to take that back to what I do and make sure that I'm, not unnecessarily not giving people cognitive treatment, since they apparently did that in this study and were somewhat successful. What they did find is that the use of adjustments to the environment, so what we think of as classical behavioral treatment, in other words, a lot of what seems to be true in people who have intellectual disability is that they are stressed by their environment. So making adjustments in the environment was helpful in that group. So I'd like to thank whoever gave me that question. It was a really good one. I learned a lot from it. And then the last question I got was, is it still the case that anti-seizure meds don't help people with non-epileptic seizures? And this is a question that's always asked when I give these talks. So, why don't we use anti-seizure medication for people with non-epileptic seizures? Well, the thing is, we in an epilepsy center, we get video EEG to diagnose epileptic versus non-epileptic seizures after we do 2 trials of anti-seizure medicines. But what I can tell you is in the community, that's not the case. This is the recommendation of the International League Against Epilepsy. I mean, people are not supposed to have seizure medicine trial after seizure medicine trial before we really find out why aren't these seizure medicines working. And the reason we do epilepsy monitoring is that after 2 trials, statistically, the third seizure medicine is not going to make a big difference. And so we better find out what's wrong with the patient's seizures. And we do that with a video EEG. The other problem with giving seizure medicines is that they delay diagnosis. And that's shown statistically. And we know that the longer people wait to get the proper diagnosis, the harder it is for them. They have negative outcomes. It's harder for them to get well. They're exposed to years of seizure medicines. They're also not given the actual treatment that they need, which is not seizure medicine. So every trial of anti-seizure medicine increased the average delay of diagnosis by 1/3 of a year. And so this is really an issue to not get stuck using seizure medicines. Trials of seizure medicines cause the diagnostic delay, and the average for diagnosis is about 7 years. That's a long time to wait having the wrong diagnosis. And seizure medicine use does not benefit NES frequency and control. And I think that's the real key point that answers this registrant's question. It does not show benefit. And I know that people will always say, oh yes, the doctor put me on gabapentin, or the doctor put me on Lamictal, or whichever medicine, and I got better. And so, we hear those stories all the time, but in large controlled studies, we show that it actually is not true, unless that drug is specifically treating an underlying comorbid condition, or, an underlying condition that's actually contributing to the non-epileptic seizures. The risks outweigh the benefits of using anti-seizure medicines unless the drug is being used for another purpose. Like many of you probably take Topamax for migraines, or Depakote for bipolar mood disorder, or gabapentin or Lyrica for neuropathic pain. And so if we're treating another disease, then it is worth it to try to use an anti-seizure medicine, even if a person does not have epilepsy, but it's not being used for the seizures. And then of course, anybody who has a diagnosis of epilepsy as well as non-epileptic seizures would get an epilepsy medicine. So I want to just switch gears a little bit and talk about our clinic and the treatment that we give. Thank Karina for her kind introduction. She already told you some of what I'm going to just repeat here. Dr. Haru and I in 2014 were actually tasked by the hospital to figure out a way to get neurology and psychiatry to work a little bit better together. And I had the good fortune to hire a young woman who's getting her master's right now, Megan Watson, who just really ended up being a huge team builder and program manager. And then I got really lucky and was able to have Dr. Libin become our clinic psychiatrist. She started out with us as a resident doing a 6-month rotation and just really loves working with functional neurological disorders. And so decided to sign on as this, our NES clinic psychiatrist. And then last year in November, we got lucky again and hired Abby Panetti. She's a licensed clinical social worker, and she does both evaluations and treatment in our clinic and does a tremendous amount of casework because, as you might expect, people with non-epileptic seizures really just need the kind of help that we can deliver. I'm also super lucky to have a whole team of advanced practice partners. Scott Pearson, Nicole Ralston, Raji Krause, and Stacy Wilson, who all help with the 6-week group that I'll talk about in a minute. And then we have a department liaison, Travis Beckstead, who just picks up some stray pieces for us. The rationale that Dr. Haru and I used is that we've got so many of these people being diagnosed with non-epileptic seizures and nothing to give them back in 2014, 2015, when we started all of this. And we just felt that it was wrong. We also have many of these patients coming to our outpatient clinics, so the problem is very real at the university level. Currently, we have our psychiatry providers actually in dual appointments with us in the neurology department. And we're in COVID times now, so nobody's actually creating a medical home in a clinic. We're all doing it virtually, but when we're in real time, we are doing it together, and people don't go over to the psych department to get their care. They get it in neurology. And also at this point in time, the number of people that we've enrolled and started to treat is over 750. So we're just growing and growing. Who do we treat? We talked a tiny bit about this. We treat people who've got a video EEG that shows that they have non-epileptic seizures. The video part we think is really important because we use it as a teaching tool. We take patients with any insurance type, including Medicaid. In fact, we have something like 45% of our patients are on Medicaid. And we take patients who are cognitively able and have potential to benefit from CBT. And after I studied the question about intellectual disability and treatment, I'm really going to have to go back and look at that again and wonder whether we should be adjusting that criterion. And then there are a subset of patients who really can't tolerate the kind of treatment that we deliver in our clinic. It's a small percentage, but it's a very worrisome kind of thing that, we don't have a lot of treatment for NES in the Rocky Mountain region. And if what we're doing isn't helpful to people, that's a problem. I'd like to just call out the Epilepsy Foundation of Colorado and let you all know that we've got an amazing partnership with them and have worked with them and with our caseworker to develop a list of providers in the community who are completely willing to take care of people with both epileptic seizures and non-epileptic seizures for their psychiatric needs. And so that's been just a boon to our work. What we do in the hospital is we diagnose the NES. We do it with the EEG. The epileptologist takes care of that. We have our certified nurse practitioners and our PA faculty provide teaching and address questions for the patients right then and there so that they hopefully leave with a whole packet. I have here Nurse Navigator. I forgot to change it. We have our program manager also meet virtually now with the patients to coordinate discharge care. We show a video, a teaching video. We then have the APP or the MD come back and answer any other questions. And every once in a while, this doesn't happen very, very often, but sometimes people need a psychiatric evaluation while they're in the hospital, and we can deliver that if it's needed as well. This is kind of a busy slide, but we do a full neurological intake, even though most of our patients have already seen a neurologist and had a history and physical done. When they were sent to the hospital to get their EMU, they got their diagnosis. I felt very strongly, and the team realized early on, that they need to come back and see a neurologist. And that's because I can open up the EEG again after they've been out of the hospital and go back over the information, make sure that we've collected the right information, make sure that we've got the right diagnosis. And then they get a full examination and evaluation by our psychiatric team as well, both our psychiatrist and our licensed clinical social worker. If needed, this is very rare, we can plan individual therapy, but what we do is we immediately create a transition plan to an individual therapist in the community if that's needed, because we don't have a lot of bandwidth to do a lot of individual therapy in the clinic. Medication management consultation with the community prescribers offered, and we do follow up with our patients. We measure things by giving questionnaires. We're measuring strengths and weaknesses prior to treatment, and then again after treatment is online. And then we have a very specific treatment modality with a 6-week group, which is a psych education group that uses a cognitive behavioral approach. The 6th session in that group is a multifamily group where we get all of the families together. This has been a real challenge with Zoom, I have to tell you, but it's actually working really much better than we thought it would, and it's been a lot of fun. The 12-week group is a psychodynamic group that explores symptoms and signs, and really in a theme-based approach. So basically, whatever comes up in the group and ends up being thematically important is what's explored in that group. So it's not as driven by education, it's more psychodynamic and insight-oriented approach. And then again, the metrics that we are always begging our patients to give us their seizure diaries and tell us how often they're going to the emergency department, and doing questionnaires. So one of the joys of doing Zoom is that my granddaughter's in the next room, and you might be able to hear her making loud noises, which my husband's supposed to be taking care of. So sorry about that. And then this is just a summary slide. Where can people find NES? Where can they find support for their NES? There are so many really, really great resources now. I'd like to point out FND Hope. I'd like to point out the neurosymptoms.org. About 4 years ago, doctors got together and created a functional neurological symptoms disorder society. And so now I'm got to be a founding member of that. And I think we're really in a time at this point where we're just moving ahead full speed and learning more and more about this disease and learning more and more about how to, take care of people with FND. So thanks so much. It's a little weird. I can't see anybody. It's always nice when I'm giving a lecture if I can see your beautiful faces, but that's the world of COVID.
So we actually do have a couple of questions, Dr. Strom. We've got a couple of minutes, so that worked out really, really well. So the first question, we have somebody asking about sudden and explosive behaviors. They're wondering if that could be NES or what steps they could take in finding a diagnosis.
Sudden explosive behaviors. So there is I'm not a psychiatrist, but there is a disorder called explosive, I forget exactly what the name of it is, but the explosive is in the name. And I think that, if you go back to this first slide where I talk about the DSM, if the criteria is going to fit a little bit better for that other diagnosis, that's something that a psychiatrist would be able to evaluate and, diagnose properly. The other half of the question is, seizures can be very unusual. And I pointed that out when I talked about frontal lobe epilepsy, because every once in a while, people can have these very strange behaviors, which are, jumping up and down, running around in circles and doing things that you would never think of as a seizure. And in fact, they're epileptic seizures. So, I need to maybe know a tiny bit more about the case to really definitively say, but sometimes, odd behavior can be seizure activity. And certainly what I can tell you is that a lot of people with non-epileptic seizures also can be very dysregulated and irritable. And I've taken care of patients who reach up and choke themselves or choke other people. And so if that's what they mean by explosive behavior, it can be associated with really what we think is at the heart of non-epileptic seizures, which is dissociation. When people are dissociated, they really don't know what they're doing. Not that anybody with a non-epileptic seizure knows what they're doing during it, but some of these behaviors can be quite challenging to deal with. And so the answer is maybe. How about that, Waffle?
Okay. Another question we have, this individual, she believes she's been living with NES for quite a while, has some PTSD and some other stresses. And so I think the bottom line of her question is, how can someone de-stress when NES isn't necessarily something they can control? Yeah.
This is the work of getting better from non-epileptic seizures. And I think that what we do, and I didn't really call it out when I was talking, but one of the things that we have integrated into our system of treatment is mindfulness activities. And, a lot of people say, oh, mindfulness, eat an apple and call me in the morning. Let's get mindful. Let's sing Kumbaya. It is a very underrated technology or technique rather. What's really exciting in the world of functional imaging is that we can see how mindfulness changes the brain. We've always known it does, because we've got yogis who can sit cross-legged for days at a time and suspend all of their bodily functions. You can change the brain with mindfulness. And one of the strengths of these is that it also gets you in touch with how you're feeling. And we teach mindfulness in a very purposeful way in the NES clinic because A, it works, and B, it is a way to de-stress. And right now with COVID and all of the other stresses that we're going through, it's especially important for people to suspend their disbelief about this particular kind of treatment, because it really works, and it only works if you work it. And I think that in large part, people have to have hope that it's going to work as well. And I think those are the key elements.
Question about rescue meds. Can you speak to rescue meds and NES?
Well, that's a question that comes up a lot. And so most patients come to us on a seizure medicine or recently discontinued seizure medicine. And because of the nature of non-epileptic seizures, seizure medicines don't help. And so people come to us with huge numbers of seizures. Anything from 2 or 3 a week, which in an epileptic seizure would be considered terrible control, up to 20 a day and even more. When we first started our online seizure diary, we only brought it up to 40, and then we had people say, I have more than that. You need to add more numbers to the drop-down menu. So the issue of seizure rescue medications comes up a lot. The problem with seizure rescue medicines is that because of the sheer number of seizures that people have, where do you cut off a seizure rescue medicine? And that it really takes a lot of patient teaching. So my goal is to keep people away from medical trauma. And the way to do that is to reduce the number of times people go to the emergency department. And so the first thing we do for seizure rescue is create a good seizure action plan. And I think that one of the people feel they need rescue is they don't know what to do when their loved one is having seizure after seizure. And so we have to have an action plan for that. And that entails, finding out what the patient would find comforting and what the patient would find safe. And, teaching the family, not only the patient, but family members how to create this plan and actually put it into action so that we don't have to use rescue medications. I have patients, not very many, who have really violent and painful and injurious non-epileptic seizures. And sometimes we have to use rescue medication. We just monitor that very carefully. And we want to always be really careful that patients aren't getting addicted to these medicines because they are addictive. And then they can, they don't work as well anymore. And people overuse them and they're really not being used appropriately. So we tiptoe around this a little bit. We use it in really extreme cases, but really the first line treatment is to find out, what seizure action plan is going to comfort the patient, keep the patient safe, and keep the family members in a place where, they're not distraught over their loved one's seizures.
I think we have time for one more question. And for those of you who did not get your questions answered, you're going to get an email from Wendy tomorrow, and you can respond to that, and she can get with Dr. Strom and perhaps answer those one-on-one. But I've got one more question we can do live. This one is, if someone only gets seizures in sleep, do you see a difference with epileptic and non-epileptic seizures?
Okay, so this is one of the things that can really help differentiate non-epileptic seizures. If a person is in a sleep mode, that is something we can see on an EEG. And what we find is patients tell us often, my seizures are in my sleep. And what we find in the epilepsy monitoring unit is that they are sleeping, but they wake up and then they have a non-epileptic seizure. So what we find is that people who think they're sleeping are in fact sleeping. They wake up and then the event happens. People who have seizures that are coming out of sleep, where we can see the background EEG is got a very specific pattern that lets us know that the patient is sleeping, and then we can begin to see the seizure evolving during sleep, then we know that those are epileptic seizures, but there's really never any doubt with that anyway. But there was a study that looked at this and looked at, quote, seizures, non-epileptic seizures out of sleep. And what it found is that people thought they were sleeping, but they in fact had awakened and then had a seizure. These are great questions, you guys. I see you.
Well, maybe I'll squeeze one more in since we're still running good on time. Here's one more. Can children who've been diagnosed with ODD be having seizures instead and just be misdiagnosed?
ODD.
I wonder if they meant ADD.
ADD?
Can children who've been diagnosed with ODD be having seizures instead of and just be misdiagnosed?
You know something, I'm not sure what ODD is, if it's ADD or if it's OCD. Though the symptoms are pretty different for epileptic seizures, unless this person's asking about non-epileptic seizures. Is it?
Oh, here we go. Oppositional defiant.
Oh, oppositional. Oh, so that's kind of like that explosive disorder that we were talking about before. The world of pediatric non-epileptic seizures is really quite a different world than that of the adult problem. And what we always teach the residents is that, you know, we've got basically people who are having paroxysmal events. So they're, you know, doing fine. And then all of a sudden with their oppositional defiant disorder, they're, you know, just acting out and not acting like themselves. And it seems like, you know, to the parent and to the family, where did that come from? They were fine. And now all of a sudden they're not fine. And that's kind of the very definition of being seized. So if you think about seizure as just what the word means, it means to be taken. People don't get up in the morning and say, I think I'll be oppositionally defiant today. It just happens to them. And so in that respect, it seizes them. The same thing with non-epileptic seizures. These are things that just happen. People don't decide to have a non-epileptic seizure. And so, you know, when we think about the world of all of the things that happen in children, there are a number of things that can mimic non-epileptic seizures. ODD is not high on that list. It's really more things like breath holding spells, syncope, micturition, syncope, various other things like that, that really seem to be higher on the list of being mistaken as something when in fact it's a, you know, non-epileptic seizure or an epileptic seizure.
Great, thank you.
Okay.
We had a couple more questions in the box, and I know there's more questions that people didn't even have time to enter, but it's all we have time for now. Dr. Strom, this was so informative. Thank you so much for sharing your expertise tonight and every single day in the incredible work that you do at the clinic. We so appreciate it. And Dr. Strom is just an incredibly valued volunteer here at the foundation. We're just so thankful for your time tonight.
Well, it was my great pleasure. Thank you.